First of all, thank you guys so much for having me. It's a real honor to be here. The format that I'm doing this presentation in is I've given a lot of these Afib talks over the years, and we tend to have very similar questions at every talk. So I figure, why don't we just go through the most frequently asked questions and kind of answer them right off the bat, and that'll kind of be the presentation. Is some of the questions that I've gotten over the years and things that people really want to know about atrial fibrillation. So when do I decide to refer for ablation or to use antiarrhythmic medications? So this is the newest European Society of Cardiology diagram looking at when you use which antiarrhythmic medication when you refer for ablation. So I like to kind of divide groups of patients up into patients with underlying heart disease and patients with no or minimal heart disease. So if you have heart failure, you actually break them up into New York Heart Association Class 3 or 4 or stable New York Heart Association Class 3. If they're stable, we can use dronedarone or Multac. You know, there's a black box warning now saying that if a patient has had recent symptoms of heart failure or Class 3 or 4 unstable heart failure, you cannot use Multac because it increases mortality in those patients. So in those patients, really your only option is amiodarone, and sometimes you can also use sotalol. In Europe, they don't use sotalol as much, but in the States, we do use sotalol in patients with heart failure. It can worsen heart failure at times just because it's a beta blocker. Stable heart failure, you can use dronedarone. Patients with coronary disease, you can't use the 1Cs like flecainide or Rhythmol, but you can use dronedarone and sotalol. So these are all first-line options. So hypertension with LVH, again, you can't use 1Cs such as flecainide and Rhythmol, but you can use dronedarone or amiodarone as a last line of therapy. And catheter ablation in those patients is usually second-line therapy. So patients with some sort of structural heart disease, we generally do try an antiarrhythmic drug. We're a very high-volume center, so we're a little bit more comfortable offering patients ablation at a little bit earlier stage. So generally what I'll do is if they can't take, we'll try them on dronedarone if they have LVH or stable New York Heart Association Class 3 heart failure. Or if they can take a Class 1 antiarrhythmic such as flecainide or Rhythmol, we'll always offer them that first because that's an easy outpatient therapy. They can take it at home. They don't have to be in the hospital. Once we move on to therapies such as sotalol or Ticacin, where they have to be in the hospital often to initiate the medication, we say, well, you know, you can be in the hospital 3 days and be on, you know, one of these medications, these Class 3 antiarrhythmic medications, or the other option is to undergo an ablation. So that's the point at which I generally offer an ablation. When it comes down to amiodarone, if the patient's younger, I call young under the age of 75, this is probably not the best drug because after 2 to 3 years, probably about a third to 40% of patients aren't able to tolerate amiodarone long term just because of eye toxicity, liver toxicity, lung toxicity, thyroid toxicity, and skin toxicity. So obviously, amiodarone is a great drug. It's a very strong drug and is good at maintaining sinus rhythm, but long term it's not the best drug for most patients that you think are going to survive a significant amount of time. When you look at patients without heart disease, paroxysmal atrial fibrillation, there's actually a pretty good level of evidence that catheter ablation can be first-line therapy. And there's actually just a trial that looked at this, and they found that as far as side effects are concerned and adverse events, catheter ablation actually has significantly less side effects at 1 year than medical therapy. It was something on the level of around 16 or 17% for medical therapy and about 6% for catheter ablation. So it was statistically significantly better than medical therapy, and that was generally in the paroxysmal AFib arm because they have generally the best results, and we'll get to that. For persistent atrial fibrillation with no heart disease, we generally do try one of these medications and try to get them back in sinus rhythm, make sure they feel well in normal rhythm, and then consider an ablation after one of those therapies fail. So patient selection, how do we pick patients for atrial fibrillation ablation? Well, first of all, they have to be symptomatic with their atrial fibrillation. So if somebody's been in atrial fibrillation for several years, 1, 2 years, generally what I'll do, first of all, you ask the patient, how do you feel? Do you think that this atrial fibrillation is causing symptoms? Once you've had it for that many years, generally you don't know if it causes symptoms or not because you're used to the way you feel. What we'll do is we'll generally try to cardiovert them, maybe even on amiodarone if they've been in atrial fibrillation for a significant period of time. Sometimes amiodarone is the only thing that will really hold them in sinus rhythm. We'll keep them in sinus rhythm for a couple months, make sure they feel better, and if they come back to me and say, Doc, you know, I feel better than I have in years. I don't want to go back into atrial fibrillation. Then we'll offer them an ablation in order to get them off of amiodarone. So that's generally how we'll do it. We'll make sure that once we get them in sinus rhythm, they're going to feel better than they did when they were in atrial fibrillation. Then there are some patients that we get them in sinus rhythm, and they really feel no different than they did in atrial fibrillation. And at this point in our knowledge about atrial fibrillation and atrial fibrillation ablation, there's no indication to do an ablation or keep them on any medications just for the sole purpose of maintaining sinus rhythm. You really have to have some symptoms in order to justify the danger of antiarrhythmic medications and the risk of atrial fibrillation in order to really offer that to your patient. So refractory to at least one class 1 or class 3 drug, and this is a relative indication for selection. I generally say refractory to at least one class 1 drug or dronedarone, so the class 1s being Rhythmol or flecainide, which you can give in the outpatient setting, and Multac you can do the same. Class 3 drugs, generally, unless they have a defibrillator, I at least admit them for a day or two. For Sotalol and for Ticastin, you have to be in the hospital for 3 days. So I generally offer my patient an ablation kind of equivalent with one of those drugs. Age under 75, probably the oldest patient we've ablated now is 83 years old. But they're a very healthy 83. They play tennis. We don't want to, somebody that's bedridden, obviously, because we're not going to do them any good. We're not going to improve their symptoms if they're not doing anything. So age greater than 75, under the age of 75 is a relative indication. If they're very active and healthy, then we'll go older than that. But they could be 65 and not active at all, and that's not a good patient for an atrial fibrillation ablation. Left atrial diameter, so if you have a very enlarged left atrium, then it's much harder to keep that patient in sinus rhythm just because they have a lot of scarring and fibrosis, and those patients generally don't tolerate being in normal rhythm for very long, and they end up going back into atrial fibrillation. If they've had atrial fibrillation for years and years, those are much less likely to be maintained in normal sinus rhythm. So those patients are going to take often more than one ablation, so they have to understand that. Paroxysmal is much better than persistent as far as our results overall are concerned. Advanced structural heart disease, so if they have severe mitral regurgitation or severe aortic stenosis, they're going to need surgery. It's much better for them to go ahead and get a concomitant Mays procedure during surgery than us go in and do an AFib ablation and then them get surgery soon after. So those are the patients that we definitely refer to the surgeons and tell them to go ahead and do their Mays procedure at the same time as surgery. Anybody have any questions about kind of patient selection and how we choose drugs and choose catheter ablation? Okay. So what's the long-term outcome after atrial fibrillation ablation? So we've been doing this. It was first described by a doctor named Dr. Hasseguer in Bordeaux, France, in 1998. And since then, we've been kind of modifying the technique, but it's essentially been built around isolating the pulmonary veins in one way or another. Probably the way we do it now has been going on since about 2004. And so we essentially have about 8 to 10 years of experience in isolating pulmonary veins. What kind of outcome data do we have? Well, we have a good 5-year follow-up. This is a multi-center follow-up trial. And essentially what they found with one procedure, they found at 5 years you had a less than 40% rate of success it was about a 35% rate of success with one single ablation procedure. However, with more than one procedure, and it was an average about 2.1 procedures, I believe, you could have a fairly good chance of success. This is about 70% chance of success, which is reasonable at 5 years in all comers. I think if you limited this to paroxysmal patients, I think it would be a lot higher. If you said all these are going to be long-standing persistent, this would probably be a little bit lower. So I think it really depends on your patient selection, how good this 5-year follow-up is. But as you see, you do have drop-offs. So what they say is that a lot of these patients, even after successful ablations, if they don't have good diabetic control, if you don't control their hypertension well, if they develop heart failure, valvular disease, if they have heart attacks, they're going to be at much higher risk for developing atrial fibrillation even after you successfully isolate their pulmonary veins and they were initially paroxysmal. So these patients, you still have to continue best medical therapy. You have to control all their comorbidities in order for them to have good long-term outcomes. That's very, very important. So there's several sources of radiation. How do we minimize radiation during our AFib ablations? Many of these patients are quite young. They need more than one procedure, and there is quite a bit of radiation associated with this. CT scans, many centers obtain a CT scan before the procedure and then one after the procedure. Fluoroscopy, the average fluoro times in most major centers are between 50 and 80 minutes per case. And some patients, like I said, have multiple procedures. How we limit this is, again, ultrasound. We're very reliant on that, and that's how we really decrease our radiation exposure for the patients. We don't use any CT scans anymore because we're able to make a full map using ultrasound. Our average fluoroscopy time is probably less than 5 minutes, and that's really all the radiation they get. And that's important, again, because they often need more than one procedure in the more advanced patients. So just in closing, I just wanted to kind of go over our institute. We started the institute in 2008. I came to St. Vincents around that time, and myself and Dr. Magnano kind of started it, and then Dr. Sippens has kind of joined in gradually. And our procedure volume has really skyrocketed, and I think that's really due to educating all our referring physicians, and I think the knowledge about atrial fibrillation in our community has really grown dramatically since even in the past 4 years. I think we've all become much more aware, especially with some of the new anticoagulant drugs coming out. I think atrial fibrillation has really come to the front of people's minds rather than kind of being on the back burner and just being something that patients have had to live with. So I think that kind of ends my formal presentation. Well, thank you all so much for your attention. You've been great.